submit my salutations to my guru, mentor, and well-wisher, Professor M.S. Oration, who passed away 3 days ago. He is a great teacher, you all know that, great academic person. Above all, to his students, he is a great supporter. And though he passed away from the earth, he is all in our hearts. All of you know him in different ways. And I submit my salutation to him. Distinguished chairpersons, colleagues and friends, I think the organizing committee must be wondering, thinking why they chose two elderly persons, senior persons to give this lecture. Because when you become super senior, you always start talking about our own history rather than any path-breaking works. So when Dr. Girish started, I thought I'm going to repeat what he said, but that was a different story. Mine is a different story from Madras Medical College, Chennai. So PATHROSE MATHAI is, Dr. PATHROSE MATHAI is a very, very loving person. I know him, like the daughter said, when I was a junior most tutor in nephrology, or not even nephrologist. And he's a very kind person. And his work on venom-related renal diseases, internationally acclaimed as a tropical nephrology journals are very popular. And his children, his daughters are very dear to him and very dear to us. With my pranams to Dr. PATHROSE MATHAI, my talk is going to be nephrology, the past, present, and the future, with my own perspective. And if you look at the history of milestones of during the first decade of MMC nephrology, though Dr. Rabindranath came in 1969 and started his dialysis, he left in a short time, and with Professor Oration came in 1971 from PGI with a lot of dreams and hopes to start a similar institute like PGI in Madras Medical College. Of course, he was offered, I don't know whether those of you who visited at that time to our place, it was a rat hole in the GH, General Hospital. But with his pursuance and hard work, he developed the Department of Nephrology with his 10 years to the level of, I can say, better than PGI. And he started in 1774 dialysis. At that time, I joined there as a tutor in nephrology. And he started the DM course, and I happened to be the first candidate. He is the founder of Southern Chapter Indian Society of Nephrology. And it was his dream to start a separate Southern chapter so that the nephrologists southern country can have better representations in the academic field. Because, at that time, ISN was different. And the first conference was conducted in Chennai. And after I graduated, I went to Stanley, and I had the pleasure of doing the first transplant in 1985 after I went there, even before it was done at MMC. And the first deceased donor transplant was done in Stanley after that. That's a little bit of my history. In the nephrology, past, present, and future, So the period of 45 years of my life journey in nephrology, I just classified into three phases. The past, that was the beginning of nephrology, that was in clinical nephrology and dialysis and biopsy, it was that period. The present is the phenomenally developed nephrology on the whole. Thank you. And it was a bloom period for nephrology, all of you will understand. That was the second decade of nephrology in Chennai. Until now, it is blooming like anything and peaking like to international level. And the game changes during this period are Southern Chapter. Of course, I can't go without saying the Association of Women in Nephrology chapter. And teaching and training and knowledge sharing was phenomenal during this period. The last decade, that was out of the teaching institutes. You all know how much it has spread the knowledge and the discussions are. The future is a dream and hope and researchers, and I am beyond the age of dream. But I would like to say a few words about beating the kidney disease. That is the future of nephrology. Dr. Girish showed you the oldest machine, that is drum dialyzer. But we had our own dialyzer in 1972. It was a tank, not made by our own engineer from IIT called Venki. We used to call it as Venki machine. And the dialyzer was, all of you know, probably from quiz, that is a keel dialyzer, which for a decade we all have to prepare, sterilize, wash next day to do the dialysis. It will take a day to do 1 or 2 dialysis in those days. And the access is squamous, and Girish showed in Chandigarh it was in the legs, and in Chennai it is always in the upper hands. And it will last for 1 or 2 weeks. Making the shunt was so difficult because the surgeons are not available. And much more difficult is getting clotted often. The declotting process we used to spend many, many hours on it. And this is the same catheter because Dr. Oration came from Chandigarh. The same whole polythene tube. The holes are made by the department with the trocar, and we used to use it. And this is a bimsilamine needle used for liver biopsy. We used to use it. And you can see at the crude type of needle this is, and compared to the sleek true cut needle now we use it. And we had fortunately we never had major problems by using that needle in those days. The imaging was the plain X-ray abdomen to look at the kidney. So from 69 to 71, as Girish said, it is only automatically. There was only 4 centers. He missed out MMC, and there also was dialysis started, was available only in the 4 centers. But now in India, more than 15,000 centers are available. I believe it covers almost 1/3 of ESRD patient. And in Tamil Nadu, we have around 650 hemodialysis centers. When we started, there was only 1 center in Chennai, and now around 650 dialysis, of which 152 were by the government. As usual, about 70%, 70 to 80% of the centers are private, and you have to pay for the dialysis. One of the greatest things that happened in this period was the government insurance. And that helped many of the people, many poor people, to go in for maintenance hemodialysis for a long time. And at present in Tamil Nadu, around 1,500 machines are available. And almost in all teaching hospitals, of course in corporate hospitals they are available. All the modalities of dialysis are available. And there used to be a debate And in the government scheme, we used to do only twice weekly dialysis. Even otherwise, the patient, we can do only twice weekly dialysis. There used to be a lot of debate at that period saying that it is not adequate dialysis. And the recent study shows, presented at Asian Kidney Week 23, which compared the twice weekly dialysis with thrice weekly dialysis. It showed there is a residual renal function, and if you do a twice weekly dialysis, it's far superior to thrice weekly dialysis, because you can see the second column is the thrice weekly dialysis with the residual kidney function, and the first three at 12 months, 24 months, 36 months, the residual renal function is maintained around from 10 to 2.9. When you do the same patient thrice weekly, same group of patients, thrice weekly, the RKF comes down to 0.9 ml. And that residual renal function is supposed to be very helpful in the longevity and survival of this patient. And of course, the KT by V is almost similar in both the groups. So this showed that voice thickness. Okay. And that showed that twice weekly dialysis is not inferior to thrice weekly dialysis, and it is renamed now as an incremental dialysis, and it is recommended for daily use in all the countries. So there are various advances in chronic maintenance dialysis, like home dialysis, nocturnal hemodialysis, short daily dialysis, hemodiafiltration. Of all this, hemodiafiltration is supposed to be superior because it removes the medial molecules. It is recommended by all because the long-term cardiovascular mortality, which is common in dialysis, is much less with that. And we have now plasmapheresis, CRRT, and all those things. All the modern, recent developed, and the hemodialysis machine now have optional devices which can check the dialysate urea sensor, which gives us an index of dialysis dose, and also blood volume sensor, which monitors the hematocrit and volume status, and that we all know is very important and very difficult to monitor. And this is a new machine that has come, which can come into use with us, because large centers have all the facilities. And there is a group of middle-level dialysis centers where it was operated by new, recently passed out nephrologists who want to do flex, who want to do ABY and other things. The centers may not have the specific machines or trained personnel. This is what we use in a middle-level centers, what is called the portable flex machines, where it comes with the 5 bags of FFI, and the other fluid is replaced with saline and cost around 20,000 rupees. And if you want to do 5 sessions for the ABOI transplant, you can go by within a lakh of money. So that is what at present we are using in the smaller centers. And the other machine is what is called the portable home dialysis machine, which is recently available. To develop a home dialysis machine is very difficult. You need a separate room and water treatment mechanism and technicians to come and do the thing and all that. But this is a portable machine which you can see, it comes like a box. He brings it and the machine is pulled up, and when you do the dialysis, these bags, 6 bags with 5 liters in each with the pre-mixed dialysate are available. And he does the dialysis and goes home. It's made in German, and it has come into use recently. These are the 2 things I think very useful for middle-level dialysis centers. So how long a patient can live on survival and dialysis? You can go even 20 years on dialysis, people are there. But in Japan, the 1-year mortality is 6.7%, whereas in USA it is 21.7%. It depends on the quality of the machine and discipline and the highly developed machines which you can monitor every aspect of dialysis are used there. And it is also increases, the survival rates are also improving in our own places, and people are living longer with dialysis. But somehow the quality of life is not very good. Hemodiafiltration, nocturnal dialysis, daily HD, home dialysis are said to be superior in terms of quality of life and survival outcome. It's available to a certain group of people in our country. So in developing countries, we know maintenance hemodialysis is not available to all. The Asian Pacific Society of Nephrology launched a program called Affordable Dialysis Price in 2017 with the objective of facilitating a design of dialysis machine that would cost less than $1,000 and provide a treatment with less than $5 a day per session and is as safe and effective as existing dialysis systems. And this will be run by solar power and water by steam distillation, purified water are available, and electrolytes get mixed up. So if this machine comes, probably everybody can afford a dialysis in our country. These are the kidneys on pipeline for long. Even before I retired, we used to talk about that. The bio-artificial kidney, wearable kidney, all of them are still under clinical trials and is still under testing, not yet marketed. I don't know whether I'll be seeing them before my lifetime. So phenomenal advances happen in transplant. You all know that. It happens not only in big centers, teaching institutes, in the smaller centers also. And the donors are redefined now as related, altruistic. They are mainly unrelated, thanks to the High Court judge in Chennai, and marginal donors. Marginal donors are the ones who expanded elderly donors, diabetics which are under control, etc. And again in the deceased donors, we have a donation after cardiac death, marginal donors, and my junior colleagues call a no-taker donors. That is, when nobody takes the kidney comes from with a creatinine of 4 or 5 milligram. Some transplanters take those kidneys and transplant. It's happening, and I do not know the outcome of that, but it's happening. I don't know whether it happens everywhere. It happens in Tamil Nadu. And one of the important things to note is the long-term follow-up of live kidney donors. Those of you who have come to ISN 23 in Calcutta would have listened to this talk by Dori Segav, who has followed 1,900 donors compared with equally with the 32,000 matched healthy non-donors over a period of 15 years. And he said the higher incidence of CV mortality is 18% in the donors, whereas it is non-donors 13%. Kidney failure is 10-fold increase in the donors, and a 10-year incidence of CKD is 31 per 10,000 in donors and 4 by 10,000 in the donors. At 15 years, 0.5% develop ESRE, and there is a higher incidence of PAH and hypertension in women donors. When we are counseling live donors for donation of the kidney, will we be able to tell these patients these complications before accepting the donation? It's a moot point. The transplant immunology has developed large, very, very highly. We used to have class 1, class 2 antibodies, but you know, a variety of antibodies. When the rejection is not due to HLA class 1, class 2 antibodies, they think these are the antibodies which are available by labs. That is, in Chennai alone, there are many labs are sprouting to do all these antibody tests, and non-HLA antibodies are detected, and it's said to be cost for about 3.5% of AMR. They are also available to for a cost, of course, very costly. And as you know, the survival of graft depends on controlling the rejection, that is, taking care of these antibodies, and there are a lot of medicines are available. So the patient will ask, how long will my transplant last? Will it last as long as a non-transplanter? If the kidney is from an younger person, young kidney, if you could avoid cardiovascular deaths, avoid malignancy, avoid infections, you can live, and the graft will live as long as you want. Similarly, the kidney donor, when you can detect subclinical rejections, it is glare, de novo DSA, and subclinical rejections, avoid de novo DSA, avoid CNI toxicity about which Giri is told, and avoid BKV nephropathy, and the patient can live beyond their expectation. And at present, the survival was shown by this, the LRD unrelated or equal, and about 70% of them live up to 10 years, and we think it's a great. But there is a group of patients, about 30 to 40% of kidney recipients, who live beyond 2 decades, 20 years and beyond. Not many analyses are available about this group, what happens to these people to live beyond. And Devan and al. Presented this. They took around 248 long-living donors, recipients, and grouped them into two, the superior group and a group to the inferior group. The group 1 had a GFR more than 45 ml, proteinuria less than 300, and the eGFR decline less than 2 ml per year. Whereas the other group 2 has a GFR of less than 45 ml, proteinuria more than 300, and eGFR decline. The donation after cardiac death, primary glomerular nephritis, and early T-cell mediated rejection are associated with the inferior kidney allograft function. That is the 20 years group. And the other group have, and if most of them had, this inferior group had de novo donors to seek antibodies. And the donor age is the most important part in deciding the longevity of the. And what you should do to make a transplant patient, live beyond 20 years, they did yearly checkup of donor-derived DSA, particularly the C1q binding antibodies, checked the eGFR. The Australian group said cell-free DNA is the most important early detector of rejection. It outperforms serum creatinine. And they say if you do cell-free DNA can discriminate between acute ABMR, chronic active ABMR, etc., all those groups, and decreases with that. And I understand that this test is available in some labs, and it could replace your kidney biopsy, and it's called the liquid biopsy. These are the various modern treatments at every level, whether the T cell is involved, B cell is involved, plasma, or complement is involved in AMR, you have enormous improvement is there. But the 10-year survival after AMR is less than hardly 54%. So next is what happened in teaching, training, knowledge sharing. Besides the teaching institutes, the teaching and knowledge sharing has improved vastly. Of course, the conference like this and WIN and all generated a lot of knowledge. But you all know that nephrology update, GP1 started in 2015, where the journals are available at your hand. This is very useful for people who are not in an institute, not in a corporate level, who cannot afford to buy, journals are very expensive. Even an article is very costly. And this brought in all the references to you, in your hand phone. Thanks to Dr. Palani Ravichandran. And next is Inform. The interventional nephrology started by Bala, and it is spread. It's very popular with younger nephrologists, and they do all kinds of, if you watch the meeting on the last Saturday of every month, you will know what all things they are able to do. Of course, it is not always the younger person. There is one senior person, elder person, who is actively in this interventional nephrology. That is Dr. Kasi Visvesaran, who is a very active person in that and helps this idea. The another one is the peculiar transplant group, that is PQRST, which discusses the peculiar. It's not peculiar, it's highly complicated transplants are discussed, and very adventurous treatments are given, and references are brought out by Shakti. This is run by Velaravind, Rajarajan, and Shakti. So popular, 600 members are there, and even Jeremy Chapman and Kasi from Japan participate in the content is so good, they participate in the discussion. And nephropathology by our Anila, I think, nephrology, transgender genes, and pathology is amazing. She changed the pathology scene during this period. What happened in my period? And with these people so active, they are all very young people, active in nephrology will spread to sky high level in the future. And lastly is the European Kidney Health Association started an initiative called Beating Kidney Disease Initiative to prevent kidney disease. It brought out so many methods like looking into the kidney failure root cause, personalized medicine, and looking into the rare diseases, etc. And they are too lofty for us to follow it. So there is a very simple way of method. Our Mahaguru nephrologist, Dr. M. And he showed us by his initiative called Kidney Health Trust Program, which he ran in villages. He used to go to the villages and collect, identify people with diabetes, hypertension, renal disease, and give effective, simple treatment at home. And he showed us that 96% of the hypertensives BP are kept at 140 by 90. 52% of diabetic HbA1c is less than 7. Another 25% was a decline in 10%. Renal failure decline was from 28 per 10,000 to 11. Strokes are declined from 10 to 1.8, and heart attacks of population are reduced. So this is a very simple method. This is how we did it in the villages. And all of us can do in some way to do that. So one of the coincidences I saw was Dr. M.K. Mani gave a lecture, PATHROSE MATHAI Oration, in the same platform 6 years ago in the Southern Chapter Conference about the same subject. It's a great coincidence, but none of my talks can go anywhere near his oration. But I was happy. And as a tribute to his service, to his innovation, we, the Women in Nephrology Tamil Nadu chapter, started a village camp. We wanted to do only the women, but all the men came. We started doing that, and we will be following them in the coming months, hoping to do something on our own part to the people at large. And all of us can do that. Thank you very much. Oh, that's it. That's a camp. Thank you.